Education and Research Manager at the Bladder Cancer Advocacy Network. Tonight we present Exploring the Bladder Cancer Clinical Trials Dashboard and Current Trials. I'd like to do some quick housekeeping before we get started. You have the option of listening to this webinar either using your telephone or the microphone and speakers on your computer. If you have any technical issues, please call GoToWebinar Tech Support that's listed on your screen on the left-hand side. You should also see a questions box in the GoToWebinar panel. Please type any questions in there as you think of it that are relevant to this webinar topic. We'll be answering as many questions as we can at the end of the webinar. This webinar is being recorded and should be available within the next 2 weeks on the Beacon website. I would like to introduce our distinguished speaker now. Dr. Jean Hoffman-Censits is Assistant Professor in the Department of Medical Oncology, Solid Tumor Division, and Director of the Multidisciplinary Genitourinary Oncology Center at Thomas Jefferson University Hospital in Philadelphia, Pennsylvania. Her clinical focus is on the management of bladder cancer with clinical research interest in identifying and evaluating new therapies. She attended medical school at Jefferson Medical College, residency at Thomas Jefferson University Hospital, and fellowship at Fox Chase Cancer Center. We also very much appreciate Dr. Hoffman-Censits leads the Jefferson team in the annual Beacon Walk for Bladder Cancer to raise awareness of bladder cancer in Philadelphia and has attended the Bladder Cancer Think Tank. Now I will transfer control over to Jeannie.
Well, hi Vanessa, thank you so much for the invitation to talk to all of you at Beacon about this important topic, and for the opportunity to represent Beacon and talk a little bit about clinical trials. So I want to just give everybody a background about clinical trials and what how we think about them prior to focusing a little bit more on the dashboard. So for bladder cancer, as docs, when we first making the diagnosis and doing the staging, just to bring everybody up to speed about how we do this, so a urologist looks inside the bladder with an instrument called a cystoscope. They can actually see inside the bladder onto either directly by visualization or onto a screen. And then during this procedure, a biopsy is taken, and this is really one of the first ways in which tumors are staged when we try to understand how advanced a tumor is and where it is in the body. When this piece of tissue is taken out of the bladder, a pathologist or specialized physician who makes these diagnoses will then look at it under the microscope, and then oftentimes as doctors we will work with the pathologist to look under the microscope as well to confirm the diagnosis. This is an example of what a low-grade bladder tumor might look like under the microscope when someone's initially diagnosed. So when we think about bladder cancer clinical trials, it's really a very broad topic. And so as doctors, we actually think about different states of disease as well as different locations. And I wanted to kind of give everybody a primer about how we kind of think about that. So the organ that we're mostly talking about is the bladder here in the pelvis. The bladder is connected to the kidneys, which make the urine, via the ureters. And then the urine comes out from the urethra. The urothelium is the lining of the inside of the bladder. It also lines the inside of the ureters and up inside the renal pelvis. So sometimes you'll see, we use different words, urothelial cancer, an antiquated term called transitional cell carcinoma, or bladder cancer. But a lot of times we're all talking about the same thing. So if you're looking on the internet for information about bladder cancer clinical trials, those words can be used, or those terms can be used interchangeably. So when you're searching for clinical trials, the trials are oftentimes going to be broken down into the different disease locations or disease states. By far the most common kind of bladder cancer is non-muscle invasive, where the tumor is really just sitting on the surface of the bladder. There's then muscle-invasive disease, where the tumor is growing into the layer of the muscle or through the muscle. Sometimes non-muscle invasive disease also involves tumor with lymph nodes locally involved in the pelvis. And there's locally advanced, recurrent, and metastatic disease, where tumors can spread into other parts of the body, oftentimes up the lymph node chain near the aorta, or the large blood vessel carrying blood down into the pelvis and into the feet. And upper tract tumors. This is a rarer location for tumors to present. Only about 8% of all patients with urothelial cancer will have tumor either in the renal pelvis or in the upper tract. And that's, again, going to be a rarer site to look for in terms of clinical trials, but oftentimes upper tract tumors are grouped in with the rest of bladder cancer. So the stage at presentation, in terms of the most common presentation, is non-invasive, when the tumor is on the surface of the bladder. And so there may be more clinical trials available for that group of patients. That's about 75% of patients. Then about 20% present with this muscle-invasive cancer. And then at the time of initial diagnosis, only a small minority have tumor that may have already advanced outside the bladder into other parts of the body. So to give you just a little bit more of an eye view, if we kind of shrink ourselves down and look at the bladder itself in terms of staging, and not just staging about how we think about this, but how the clinical trials are broken up, really we'll draw a line in the sand here between tumors that are TA, non-invasive, or T1, superficially invasive into connective tissue, versus those that are invading T2 and beyond into the muscle layer or into lymph nodes. So a clinical or a pathologic stage comes about by first, which is the T stage, or how locally invasive it is into the organ itself. The next comes the end stage, or what regional lymph nodes may be involved. We learn this both by scans, could be CAT scan, MRI scans, or when the tumor comes out, the surgeon does a resection or a lymph node dissection. We then will group it based on the end stage, or M stage, the presence or absence of distant metastatic disease. We put those combinations together into a T and an M stage, and then come up with a final stage of disease. So again, some of the clinical trials are specific only to certain stages of disease, and this is how we come up with that notation. So clinical trials, like I said, are broken up into disease state and disease stage. Including it in disease state is whether or not somebody has ever been treated before. So some clinical trials really only include patients that have never gotten any kind of therapy, never gotten BCG before, or maybe patients who have never gotten chemotherapy before for their advanced disease. All clinical trials are going to include something called eligibility, and that is expands on who the clinical trial is going to include, which patients. I really can't think of too many clinical trials, if any, in bladder cancer that would include everybody that ever had bladder cancer, including non-invasive disease or patients with advanced disease. Those kind of patients, those kind of trials may be something like smoking cessation in all patients with bladder cancer. All those trials are going to have something called inclusion and exclusion parameters. So inclusion parameters would be something like patients who've previously had BCG and have had recurrent disease with no evidence of tumor outside of the bladder. And exclusion might be something like most trials will exclude patients with severe other medical comorbidities like severe heart disease or prior organ transplants, because we're using medications that have a lot of toxicities. A lot of clinical trials will, for instance, exclude patients with active HIV or hepatitis. A lot of trials will also have arms, and this is whether or not a study is including just what's called one arm or single arm study that's looking at drug A in the entire population. Some trials will have two arms. A lot of times those studies are randomized studies, meaning that a new drug is being tested against prior standard therapy, or even multiple arms, where there may be 4 or 5 different options in terms of which arm patients can go in. A lot of times, in a lot of clinical trials that are called randomized, both neither the patient nor the treating study doctor have the option to put patients into one arm or another. It's often just randomized. Then there's different phases of studies. In general, we talk about 3 phases of studies: phase 1, phase 2, and phase 3. I think phase 1 and phase 3 are the easiest to talk about. So phase 1 really is looking at drugs that are oftentimes right out of the lab, have been tested sometimes in animals, and sometimes have been tested previously in people, looking for the best, safest dose to treat a larger group of patients. With phase 1 studies, as investigators, we're often not necessarily looking to see whether or not a drug is effective, although we do measure that. We're really looking to see, is this drug tolerable? What are the side effects that we're looking for? And what is the best and safest dose to treat a larger group of patients? Sometimes phase 1 studies will include studies where a drug has never been combined with another modality of therapy before, such as with radiation. I'm going to drop down to phase 3 studies, where once we get more information about a drug, we know the dose and it's been tested in a larger group of patients, then a phase 3 study is typically a new drug compared to a standard therapy, or a new drug combined with a standard therapy. And the goal of these very large studies is to move a drug from an investigational agent into one where more people can get the drug, and the drug can be FDA approved. A phase 1 study may be comprised of maybe 10 or 20 patients. A phase 2 study is once you have what's called the maximum tolerated dose, is typically about between 40 and 200 patients, sometimes smaller, sometimes larger. Sometimes a phase 2 study is randomized, where there will be 2 arms. Sometimes it's just 1 arm. And a phase 3 study, are those studies that are much larger and can be hundreds or even thousands of patients. Sometimes these are called registration studies, where drugs are then, if the study is positive, meaning that the outcome that's expected with a new drug being better or less toxic than a standard, will go for FDA approval. So in terms of lines of therapy, this is another thing that we look at what you can look at when you're searching for clinical trials. So again, if you take this, go back to this original picture in terms of the sites of different therapies, lines of therapies would include, for non-muscle invasive disease, patients who are BCG naive or never been treated with local BCG therapy before, versus those that are BCG refractory. So most non-muscle invasive disease studies will include one or another group of these patients. For muscle invasive disease, oftentimes our studies are including bladder preservation studies, such as radiation studies, preoperative or neoadjuvant chemotherapy studies, looking at different kinds of systemic chemotherapies, either that go through the vein, the mouth, or both, or postoperative or adjuvant studies after the bladder is removed. There's then recurrent or metastatic studies. And again, just like we use the words urothelial and transitional interchangeably, we oftentimes will use recurrent or metastatic when the tumor goes outside of the bladder into other parts of the body, also interchangeably. First line is oftentimes the first systemic chemotherapy that someone has gotten. That typically means someone who's never gotten IV chemotherapy for their advanced bladder cancer before. And then there'll be second line and beyond studies. And in bladder cancer, you will see as a subheading oftentimes cisplatin eligible and cisplatin ineligible. So for advanced bladder cancer, cisplatin is chemotherapy that's the backbone of a lot of our chemotherapy regimens. It's a very active agent in bladder cancer, and it's considered the standard of care for patients with locally advanced or recurrent bladder cancer. Cisplatin, though, is a tough drug. It can be a toxic drug and difficult for some people to manage, and therefore not everybody is felt to be a good candidate for cisplatin. So we really think about whether or not, based on some criteria, which I'll go over later, someone can get cisplatin or not. So I want to go to navigating the Beacon dashboard, and I'm going to escape from this presentation and go then to the dashboard. For those of you who may or may not have seen this site, so if you go onto the Beacon site, there's a couple different ways that you can get onto the dashboard, but I think the easiest way is to click here. And hopefully now that we've gone over that background, this may be a little bit easier to navigate. So there's a couple different ways you can look at clinical trials. This gives a good background about clinical trials. And you can start here by going to select a category. And here are the different categories that we just talked about: non-muscle invasive, muscle invasive before surgery, upper tract before surgery, and et cetera. So you can go that way and look for clinical trials. You can also just put in your zip code and then decide whether or not you want, how far you would be willing to travel for a clinical trial, 25 miles or less, or 250 miles or even more. The other thing you can do, if you're just looking for a specific kind of agent, is hit this button. This will give you all the clinical trials at once. And so you can kind of scroll down. One of the things that Vanessa and I were talking about earlier is that this is a very specialized site for patients and families and caregivers who are looking specifically for studies in bladder cancer. But unfortunately, it's tough to make this an exhaustive and up-to-date list. It's fairly up-to-date, but clinical trials are always opening and closing and going on hold. And thus, this is a great place, I think, as a continuing and ongoing resource, but it may not be an exhaustive list, and I can give you some more information about that. And then the other thing is this button will give you all the different locations where Beacon has listed as clinical trials that are ongoing. The other way you can navigate this page is to go down here to clinical trials. And again, you'll see the subtypes we were talking about before: non-muscle invasive, muscle invasive, surgery, chemotherapy and radiation, and metastatic disease. As a medical oncologist, I give a lot of chemotherapy, and so a lot of these are the diseases that I treat. So as a, for instance, you hit metastatic disease, non-cisplatin-based chemotherapy, you can look at this study here. If we click on more details, this will then give the site with a lot more information. And I think this is a great tool that Vanessa and the team have added in, can share with friends or family just right here from the site, now that everyone's using social media, to pass along information about a clinical trial. Some people might even use this to communicate with their treatment team or with their doctor. This gives that disease state that we talked about. So for this trial, this is a second-line trial, meaning someone has already gotten a platinum-based chemotherapy, or frontline or first-line for people that cannot get chemotherapy. It gives you the name of the drug, and then it gives a little summary about what the study is looking for, the doses, and things like that. This then, if you scroll down, will give you the eligibility. So who is the study looking for? A lot of times, clinical trials in bladder cancer are specifically looking for patients that have the urothelial subtype or transitional subtype. There's other differentiations in bladder cancer, including small cell bladder cancer. Oftentimes, patients with small cell bladder cancer are not included into clinical trials, and that's because the behavior of the disease is quite different than urothelial or transitional. But most clinical trials will allow for a component, at least, of a dedifferentiated subtype, such as a sarcomatoid subtype, adenocarcinoma, squamous differentiation. But those specifics can be included here. Oftentimes, clinical trials, actually all clinical trials, will include what's called the Eastern Cooperative Group Performance Status. That is a measure, it's a crude measure of fitness of a patient that would be going on a study. A performance status of 1 is somebody who's up and about working full-time with absolutely no restrictions, where a performance status of 2, where most trials will cut off, is someone who spends at least half of the day in a bed or in a chair. A lot of studies are also looking at least in the metastatic or advanced setting, things like peripheral neuropathy or numbness or tingling in the fingers and toes. That's an unfortunate consequence of a lot of the therapy that we give, and that consequence and that toxicity can be cumulative. And a lot of therapies, both traditional therapies or already approved therapies, as well as those in investigation, will have that side effect. So that's something that we look for. Then there's exclusion criteria. And the exclusion criteria are things that the trial sponsors feel may be unsafe for patients to be exposed to this drug. Things like, of course, pregnancy. That's an across-the-board exclusion for clinical trials. People with HIV, serious cardiovascular disease. For newer studies that include immunotherapy like this one, anybody with a history of autoimmune disease would be excluded or not be able to participate in this study because there's a concern by the sponsor or the company that's running the study that someone could actually be harmed potentially by the mechanism of the drug. And then the locations for the trial. So this gives you all the different places that the trial is open. So if you click here at Jefferson, and if you're interested in learning more about the study or making an appointment, this gives you our website, our contact information, and depending on the study, different information. This also gives, again, not an exhaustive list, but other trials that are ongoing at the same center. And the same is true in terms of other disease sites. So if you look at the non-muscle invasive disease, a complete list. The other thing that you can do, like I said earlier, is type in your zip code, select a category, muscle invasive before surgery, and this will pull up some of the clinical trials available for patients that are considering going to surgery and their doctor has recommended chemotherapy beforehand. So if we go back to the presentation, Vanessa and the team at BCAN have asked me to just highlight a couple of interesting clinical trials. They're all very interesting, but those that might be of particular interest to folks who are looking at the BCAN website or for patients that have signed up for the webinar. So I wanted to focus on really 3 areas. The first is for what's called bladder preservation for BCG refractory cancer. The next would be for chemotherapy with a heat shock protein inhibitor. And then the final is immunotherapy for advanced bladder cancer. So the first clinical trial is this one. The RTOG, a lot of their clinical trials in bladder cancer are run by things called cooperative groups. So these are groups of investigators at major cancer centers with interest in certain disease sites, meaning like interest in genitourinary disease or gastrointestinal cancers. And these investigators will get together and run the clinical trials together because at each individual hospital, like Jefferson or others, it would take years to get a clinical trial up, completed, accruing in the number of patients needed in order for us to accurately assess and answer as to whether or not a drug is a good drug to move on for FDA approval and whether or not this drug is safe. So in order to get clinical trials done faster, we work together in cooperative groups. And the RTOG, or the Radiation Therapy Oncology Group, is one of those groups where they focus on not just radiation trials for bladder cancer, but studies for prostate, colon, lung, all different kinds of cancers. So the name of this study is a phase 2 protocol for patients with stage T1 bladder cancer to evaluate bladder preserving treatment by radiation therapy with radiosensitizing chemotherapy following a thorough transurethral surgical staging. So the eligibility for this study is for patients who are being treated for non-muscle invasive bladder cancer, or T1 bladder cancer, who've had an appropriate course of BCG, and despite that have their cancer come back. So this is a population of patients where the options are somewhat limited in terms of what to do. For these patients, some doctors may recommend a radical cystectomy or the bladder come out. Others may try and do additional kinds of therapy. And that's really a topic for, a bigger topic for even another complete webinar. But the idea behind this study is, can patients get what will be considered standard radiation therapy with a systemic chemotherapy to sensitize the tumor to the radiation and to see if the outcomes can be better. So these are two accepted chemotherapies that have been combined with radiation in the past. The first is called cisplatin. This is a lower dose than we give with patients with advanced cancer without radiation, or a combination of two drugs called mitomycin and 5-fluorouracil. This would be a study where it would be randomized, and the investigator wouldn't have a choice, and the patient wouldn't have a choice as to which one of these chemotherapies it would be randomized to. But following completion of radiation and chemotherapy, would then look for whether or not there was residual tumor inside the bladder with a cystoscopy. And if there was a complete response, meaning no evidence of tumor after completion of chemotherapy and radiation therapy, then the patient would just undergo ongoing cystoscopic surveillance. So at intervals that you discussed with your doctor, looking back up into the bladder, looking for recurrent disease. Or if patients went through the chemotherapy and the radiotherapy, and following that there was still residual tumor within the bladder that was not killed off by this powerful combination of therapies, then the recommendation would be for a radical cystectomy or for the bladder to be removed. Both of these are with the intent of curing the disease. So for each of these studies I'm going to highlight, I'm just going to briefly go over some highlights of who this study is really targeting. So for this population, it's for patients with urothelial cancer for whom a cystectomy is being considered by their physician. The stage is T1, and X means that nodes either cannot be assessed by any radiographic studies, or what's felt to be clinically N0, which means that the lymph nodes are felt to be not involved by those studies. M0 meaning no evidence of metastatic disease. And this is only for transitional cell histology. So as I mentioned previously, not every tumor that arises within the bladder is transitional or urothelial. Sometimes there's tumors that are called dedifferentiated tumors, or tumors that are pure, other kinds of histology such as squamous cell histology, but this is only for transitional cells. You have a TURBT, which is a transurethral resection of the bladder tumor. In order to get adequate staging, it is standard to get a biopsy that includes a sample of the muscle in the specimen, and there should be no evidence that the tumor is invading into muscle. And these are for patients that have failed standard treatment, that means BCG refractory, or is not medically eligible for biologic therapy or chemotherapy. So a patient who has medical reasons where BCG would be contraindicated. And the primary objective of this study, because every clinical trial is going to have a question that needs to have a statistically significant endpoint at the end, so the primary objective of this study is to look at the rate of freedom from cystectomy, meaning patients who can keep their bladder, and freedom from development of local or distant disease at time points of 3 and 5 years. And this study is enrolling throughout the country. It's not at every center. There are some specialized centers that will have this study open, but this is available on the Beacon website for additional questions and information. The second study that I want to review is this one called the Borealis-2 clinical trial. This is a randomized phase 2 study comparing docetaxel alone to docetaxel in combination with a study drug called OGX-427 in patients with relapsed refractory metastatic urothelial cancer after receiving a platinum combination regimen. The Hoosier Cancer Research Network Group is another clinical trial cooperative group that kind of oversees and coordinates major cancer centers to run clinical trials. For this study, this would include patients with advanced urothelial cancer who've received at least one prior platinum chemotherapy. As a, for instance, that might be somebody that has recurrent disease after having bladder removed and was maybe treated in the first-line setting with carboplatin and gemcitabine, and after a few cycles of that, had progression of their disease. There is no standard second-line therapy for patients who've received a platinum-based chemotherapy, either in the neoadjuvant or preoperative setting, following cystectomy, or in the first line. And therefore, drugs like docetaxel or another drug called paclitaxel that have some activity in bladder cancer are considered reasonable backbones for therapy. And thus, this study is randomizing patients to a chemotherapy, FDA-approved chemotherapy called docetaxel. It's given every 3 weeks. Docetaxel is a chemotherapy that we use for other cancers as well, like prostate cancer, breast cancer, lung cancer. And that will be randomized to that regimen every 3 weeks versus the exact same chemotherapy, the same dose and same schedule of docetaxel with weekly treatment with the study drug called OGX-427. The population of patients in this study is going to be different. It's patients with metastatic or locally inoperable advanced bladder cancer. And this would include cancers of any of these sites, the bladder, the urethra, the ureter, and the renal pelvis. If they have a component of non-urothelial cancer, they would be eligible. They have to have measurable disease. And what that means is that on a CT scan or an MRI scan, a tumor that's at least a centimeter in size that can be measured by a radiologist. And they must have received prior systemic chemotherapy with a platinum, but not too many chemotherapies in the past, so up to only 2 prior systemic chemotherapies. So that might be gemcitabine and carboplatin in the first line, followed by another drug called pemetrexed in the second line, and this drug could be given in the third line, or this study could be given in the third line. These patients have to have progression during or after treatment with a regimen that includes carboplatin or cisplatin, or preoperative chemotherapy with disease recurrence within a year. The primary objective of this study is to determine whether or not docetaxel administered in combination with OGX-427 provides a benefit in terms of overall survival compared to docetaxel alone. So I want to give a little background about the agent OGX-427. It's also called epitosarin. So what OGX-427 is doing is targeting an endogenous protein called heat shock protein. And just to give a background about the medications and the different agents that we use in clinical trials, clinical trials nowadays are somewhat different than they were 10 or 15 years ago, where we were using or trying to come up with different kinds of chemotherapies. Chemotherapy drugs like cisplatin, gemcitabine, carboplatin, these drugs were developed years ago. And they work in a somewhat similar fashion given through the IV and then inhibit the ability of cells to divide and to grow and renew themselves. And they do that in somewhat similar fashions. And they do it really without selection. Cancer cells grow faster than normal cells, and so chemotherapy that inhibits cells from renewing themselves will then target cells that are growing faster than normal cells. But that's too why we have toxicity from chemotherapy, like hair loss and gastrointestinal toxicity. So in the past 10 to 20 years, newer drugs that are being developed for cancers are really based on the understanding of what makes a cancer cell different than a normal cell. In all of these drugs, it's what we're really trying to interrogate and trying to target is understanding why a cancer cell is a cancer cell, why it renews itself more than normal cells, why it invades into neighboring neighborhoods where it doesn't belong, why it moves from one part of the body than the other. Normal cells don't do that. So if we understand more what cancer cells do and what makes them different, if we target those differences, we can hopefully kill the cancer, but then not cause toxicity to normal cells. So this drug is targeting heat shock protein 27, and it's a protein that protects cancer cells by helping them stay alive and lead to treatment resistance and more advanced aggressive cancers. Heat shock protein is limited in normal cells and upregulated in a lot of different kinds of cancer cells. And this agent is designed to inhibit the production of OGX427 and hopefully make cancer cells more susceptible to chemotherapy. And for all these different agents, you can go on the Beacon website or individual websites, but this gives you a little idea about heat shock protein 27 and its role as a chaperone in different proteins within the cell. It's upregulated in times of cellular stress, and if this is inhibited, it's a protective mechanism that we can hopefully take away from cancer cells. The last group of studies that I want to highlight are two immunotherapy studies. And these are, I think, pretty exciting studies for bladder cancer and beyond that I think we'll be seeing a lot more of in the coming months and years. So this study is partially completed to accrual, which means that no more patients can go on the study. Every clinical trial will have what's called an endpoint, and a number of patients that are needed in order to answer the question of whether or not a drug is potentially better than a standard option. But this current cohort number 1, this clinical trial is still enrolling. So this trial is a phase 2 multi-center single-arm study, meaning all the patients on the study get this agent. There's no randomization, of NPDL 3280A in patients with locally advanced or metastatic urothelial bladder cancer. The eligibility, these are for patients with locally advanced or metastatic transitional cell carcinoma of the urothelium, and everyone gets this drug, NPDL 3280A, every 3 weeks. Patients will come off this and other studies if the cancer progresses or keeps growing despite the therapy, or a patient is unable to tolerate the treatment for any reason. So the population of patients is, again, for locally inoperable or advanced urothelial cancer of any site, including the bladder, urethra, ureter, and pelvis. A component of non-urothelial carcinoma are eligible, and again, have to have measurable disease that we can see on a scan. A lot of clinical trials moving forward will require that patients sometimes have to undergo a new biopsy or submit tissue that has already been resected, because the studies are so specific for proteins that may be upregulated in one person's tumor or not another. We know that in some studies, if the target is not, or if the abnormal protein is not present on the cancer cell, then a patient may only be exposed to toxicity of a drug, but without the potential benefit of that drug if there's no, if the tumor doesn't express a certain target. So this is an important thing, not always a comfortable thing to go through, but this is a reason why a lot of studies will include requests for either previous or new tissue. In this study, the first cohort, which was patients who have previously had platinum-based chemotherapy and had progression, that cohort has completed accrual, meaning the number of patients that were expected to go on study have gone on study and are now being followed. But there was a second group of patients, and this group of patients where the study is currently open are for patients who are unable to get platinum-based chemotherapy due to the following reasons. Now, this is a definition only for this clinical trial. That doesn't mean if someone falls into this category that their doctor at home can't treat them with cisplatin for any other reason. But these are the general considerations that we look at for anyone who are considering giving cisplatin. And this would be impaired renal or kidney function, hearing loss, peripheral neuropathy as grade 2 or greater. Grade 2 peripheral neuropathy would be somebody that has continuous numbness and tingling in the fingers, perhaps starting to drop things at home because of that neuropathy. And an ECOG performance status of 2, which means that unable to work full-time, spending a lot of the day either in bed or a chair. And the primary objective is to determine the objective response based on tumor measurements. This is a second study. This is a phase 3 randomized trial of pembrolizumab, or MK3475, that's compared to either paclitaxel, docetaxel, or a chemotherapy drug called vinflunine. Vinflunine is not FDA approved in the United States, but is approved in Europe. And therefore, in Europe, the comparator arm will be vinflunine, but in the United States, docetaxel or paclitaxel. And this is for patients with recurrent or progressive metastatic urothelial cancer. Once again, just like the docetaxel OGX study, the eligibility or the population is for recurrent or inoperable bladder cancer. And it's a randomized study where patients will be assigned to either docetaxel or paclitaxel. That's at the discretion of their treating physician. It's a dose of chemotherapy every 3 weeks compared to pembrolizumab IV every 3 weeks. And again, like the docetaxel OGX study, this study is for patients with advanced bladder cancer who have previously had either in the preoperative, postoperative, or advanced setting a platinum-based regimen, either cisplatin or carboplatin, and again, able to provide tissue for analysis to look for what's called the target. The primary objective of this study is to compare overall survival in patients treated in the 2 different groups. And the mechanism behind both of these agents is something called immune checkpoint inhibition. And again, this is this entire pathway, immune checkpoint inhibition, also called PD-1, PD-L1 inhibitors, getting a lot of press because not just patients with bladder cancer are participating in clinical trials with these agents, but patients with all different kinds of cancers. And in fact, one of these agents is already approved for patients with advanced melanoma. And the idea behind this entire kind of pathway is that the immune system, part of its job, not just to fight off infection, but part of the job of the immune system is to recognize cancer cells as foreign and to kill them. And one of the ways that tumor cells grow and evade the immune system is by developing a defense mechanism against that. And we've learned over time that one of these defense mechanisms is called this PD-1 pathway. So the way in which immune cells, called T cells, interact with their environment are these receptors, and these receptors will, on the outside of the cell, will communicate either with a ligand that's presented by something called MHC from a tumor or other cells, or another ligand on the cell or any other body cell itself. And essentially what T cells and immune cells are doing all day long is really, it's almost like they're satellites in space, constantly docking and undocking with normal cells, with cells that may be infected with a cold virus or other kinds of viruses or bacteria, and deciding whether or not that cell should be left alone or whether or not that cell should be killed, and then an alarm should go off that other immune cells should come to this foreign or infected cell to get rid of it for good. What some tumor cells have done is use this pathway to hook up to T cells so that the T cell doesn't recognize the tumor cell as foreign, but recognizes it as a cell that should be just quietly left alone, and the T cell moves about its business. With drugs in this pathway that are being developed, a lot of them are called antibodies. They interfere with this connection such that tumor cells are no longer able to hide themselves from the immune system. And theoretically, if this T cell then recognizes the tumor as foreign, it will sound alarms, have other T and immune regulator cells, as well as proteins called cytokines, upregulated to kill off not just this tumor cell, but the entire population of cells. And that's the idea behind drugs in this pathway. Some of them are called PD-1 inhibitors. Some of them are called PD-L1. L is for ligand inhibitors. They have slightly different mechanisms and toxicity profiles. Some of them are called CDK4 inhibitors. But all in all, this is an exciting pathway of agents that are being investigated, again, not just in bladder cancer, but many other cancers. And in fact, this is the current cover or recent cover of Nature, talking about all different kinds of what's called immune checkpoint blockade in cancers, and a lot of the exciting new studies that are coming down the pike. So I wanted to take this time to open the floor up for questions, and thank you all for your attention.
Thanks so much, Jeannie. I'm going to change the slide over to our Q&A slide, and we can get started. For the first question, what is the best way to evaluate these trials and to decide if you want to participate, and do they usually contain a control group?
So probably the best way to decide whether or not you want to participate in a study or whether or not you're eligible for a study is to bring up the conversation with your doctor. It's tough, nowadays with, coming into a doctor's office. Not everybody has the, opportunity to sit down and go exhaustively over clinical trials. So I think, being prepared ahead of time, either with, webinars like this or going onto the internet, is a good place to start in having a list. You might want to, call ahead to the doctor's office ahead of time and say there's some clinical trials I want to discuss. And if you have things that you can bring off the internet, I think that would be helpful. There, a lot of what's called tertiary cancer centers or NCI designated cancer centers, will do clinical trials, but not every doctor does them. And so depending on where you are, there may be kind of different kind of comfort levels. But I think starting with definitely talking to your doctor to see, whether or not, this clinical trial seems to be right for you is a good place to start. And what was the other part of the question, Vanessa?
Do the trials usually contain a control group?
Yeah, so that's a great question. It really depends on the study. So I presented a few studies here, some that had no control group, meaning everybody got the same treatment. That was the MPDL study, was that one, versus the other one, like the docetaxel versus docetaxel plus OGX. The quote-unquote control group is, chemotherapy, which would be considered a standard kind of treatment. Then there are some studies that are going to have a control group where it's best supportive care, meaning, going back to doctor and being evaluated, but not necessarily any treatment. So that's something also to look into when you're looking at the studies. And it'll say something like the arms. Studies that will, in the title, have randomized. Those mean that there's going to be two different, or at least two different arms.
Okay, thank you. For the next question, does the investigating doctor on the clinical trial become your acting physician during the trial period?
So that's a great question. So if you come from another center for an evaluation for a clinical trial, then your oncologist is typically always available, and your oncologist. I see patients that travel, hours to come to Jefferson for clinical trials, and they may come to Jefferson for a day or two and then go back home and come back 3 weeks later. So they need to have a relationship with their doctor closer to home in case they need, an evaluation for something like maybe a rash or a refill on a nausea medication. And so oftentimes, the majority of times, we're working with someone's home oncologist. There's sometimes where, patients or their treating doctors say, you know what, from now on, we think it's best that you stay, with this doctor. But a lot of times it is it's a team effort.
Okay. Thank you. For the next question, if you feel like you can answer it, does the patient pay for the care he or she receives in a clinical trial, or who pays for that care?
Right. Vanessa, these are all outstanding questions. You have such an educated audience here. So typically when a clinical trial agent is not FDA approved, the sponsor, and that sponsor could be a pharmaceutical company or it could be one of these cooperative groups, they pay for the agent. When a clinical trial, prior to a clinical trial getting up and running, there's usually something called a Medicare or cost analysis that goes through, where I, as the investigator, will say, well, if a drug is being given every 3 weeks, we would typically give a comparator drug every 3 weeks as well. So a doctor's visit, standard labs, excuse me, time in an infusion chair, infusion, nursing fees, all those things would be considered standard. So they oftentimes will get billed to insurance. And a lot of insurance companies will accept that, understanding that clinical trials are a very, important part of cancer care. But the important thing is that if this is a question that people have, that you should definitely check in with your insurance company if this is a concern, prior to getting started on a clinical trial. And oftentimes this is going to be a part of the consent, which is a lot of times a very long document that the trial physician will go over with patients. The cost is typically in the consent, where it will outline to the best of our abilities what are things that are being covered by the trial and things that aren't covered by the trial. These studies are very different than trials that are sometimes run looking for, say, metabolism of a new drug in healthy volunteers, where patients actually get paid to be a part of the study. Those are not these kinds of trials. But many times, probably not every time, but many times, the agent itself is provided free of charge.
Okay. Thank you. For the next question, is there any way to find out the research results for yourself?
So yeah, this is a tough question. Usually there is not a direct way to find out. Say, for instance, whether or not you are a participant on the control arm of, say, an adjuvant study, meaning a postoperative study, or whether or not you got the active drug, or if you've got docetaxel alone versus, docetaxel plus, a comparator. Sometimes you actually know up front, and you'll know that in the consent form whether or not you're on one group or the other. But if it's a blinded study where both the patient and the investigator don't know, then you oftentimes will not ever get the chance to know. Neither will the investigator will get a chance to know which arm somebody's on. But as a patient participating in the study, you do have the right to be updated as to what's going on in terms of publications for the study. So if you continue to see your study doctor or in contact with the study doctor, because a lot of times, even if a drug is being given, say, for 6 months, you'll be followed either in person or by phone for years. That's the time where you can say, did the poster get presented yet, or did the paper come out yet? Where you can hear about the study in general, but usually can't get a specific understanding of where you were in the trial.
Okay. Thank you. For the next question, this person asks, are there any clinical trials available for a person with bladder cancer with the sarcomatoid variant? Or how would that person go about finding a trial for that?
Yeah, that's a tough question. So, as I said earlier, that the majority of studies that are out there for urothelial cancer, which is also called transitional cells, that's the subtype. That's the kind of aberration of a normal kind of epithelium of the bladder. But then there are tumors that kind of de-differentiate, as for instance, in patients that have a disease called schistosomiasis, which is a disease that we really see in Africa and not in the United States. Well, those patients can get what's called pure squamous cell carcinoma. It behaves somewhat differently than urothelial cancer. We don't really have a lot of trials for pure, squamous cell. For pure non-urothelial studies, they are tough. I know of definitely one called a study of cabozantinib that's run at the National Cancer Institute that is really looking for patients that have non-urothelial histologies. In addition to the Beacon website, when the Beacon website will connect you to each study to something called clinicaltrials.gov. And for every site, it can connect you to that. So that's one way of going it, or just clinicaltrials.gov. And on clinicaltrials.gov is an exhaustive list of every clinical trial throughout the world. And you can try, and there's a text box where you can type in urothelial or bladder cancer non-urothelial. Seeing that this question was submitted a little bit earlier, I actually tried to do that, and it is going to be challenging. One thing that patients may want to try is, those of us who treat bladder cancer for a living, there's not that many of us. There's probably a few hundred of us that across the country, and then out into the world, that really get up in the morning and develop clinical trials for this disease. And we actually kind of know each other and communicate at meetings and on email, and we read each other's publications. And so through just general communication with doctors, you may be able to then find networks for even rarer kinds of cancers, such as small cell bladder cancer or a non-urothelial variant. And probably the best place to start is with your oncologist or urologist to get that chain going.
Okay, thank you. For the next questions, these are kind of related to clinical trials in Canada. And the questions are trials taking place in Canada? Is availability possibly earlier for new immunotherapy treatments? And does the Beacon dashboard show trials in Canada? In terms, I'll just answer for the dashboard quickly. Right now, I believe we have the Vancouver Prostate Center, but we don't have a lot of Canadian sites yet, just because of the zip code system that we use to look at locations. But Jeannie, can you speak more about kind of availability of trials in Canada?
Yeah, so there's a Beacon investigator at Princess Margaret Hospital in Canada that I just know her because she comes to the meetings, and she has some studies open. And the clinicaltrials.gov, that website will have a map that you can click on. And again, it's a little bit cumbersome, but you can use the mapping portion of clinicaltrials.gov that will show different areas around the world that are running clinical trials. So you can specifically target Canada, and then after targeting Canada, can search for specific bladder cancer studies. Specifically about what's going on in Canada, I can't speak to that, but that's a good place to start. And the NCI Canada, National Cancer Institute of Canada, they will have a website that you may be able to look specifically for studies as well.
Okay, thanks. For the next question, this person asks, what is the best course of treatment and or clinical trial to keep non-muscle invasive bladder cancer at the TA stage between 3-month cystoscopies? And asking about BCG compared to mitomycin C as well.
Yeah. So we all wish we knew what the what the best thing to do was, and unfortunately for for each individual patient that answer might be different. Most major centers, the non-muscle invasive disease that's treated with BCG is handled by the expertise of urologic oncologists or urologists with subspecialty training in bladder cancer. And so that's really not my area of expertise. But there are, definitely room for improvement in terms of the options that we can provide to patients. As many of you might know, BCG is an immunotherapy that is instilled into the bladder with the idea of really stimulating the immune system to recognize and then fight off the tumor. This is not an easy treatment for everybody to get through. Some people do better than others, but there are some people that have disease that comes back despite getting BCG, and BCG is in shortage right now. So we are, actively looking for other medications that, trying to do better than we're able to do right now to hopefully get rid of the disease for good.
Okay. The next question was, does the VA participate in clinical trials?
Does the VA participate in clinical trials? Vanessa, I don't exactly know the answer to that question. I do know that we see patients from time to time from the VA system. And again, I think the best thing to do is start by talking to either your primary provider at the VA, your urologist, or the medical oncologist at the VA, and going from there. But I am not sure of the exact answer to that question, Vanessa. I'm not sure if you know the answer to that either.
Okay. And I think we have time for about one more question, so I'll end with this one. What current trial are you most excited about to deal with metastatic bladder cancer?
So I think that, the entire pathway, the PD-L1 pathway, is really interesting, not just for bladder cancer, but for so many other kinds of cancers. There's, different companies that have developed different agents. So whether or not it would be one agent versus another, or a combination of agents, or agents with chemotherapy, I think to again, better understand what makes a tumor cell different than a normal cell, and to potentially, come up with drugs that are either complementary or potentially even better than we may have now, with very different toxicity profiles. I think it's an exciting time to be a doctor and an investigator who's interested in learning more about these agents, so we can treat and hopefully cure more patients with bladder cancer.
All right. Well, thank you so much, Jeannie. We really appreciate your presentation and taking the time tonight. That's all the time we have right now, but please stay tuned. We've recorded this webinar. It should be available on the Beacon website soon, and stay tuned for more webinars in 2015. Thank you all. Have a great evening.
Thank you.